Hello, podcast listeners. This is Zachary Threlkeld from Stanford University. Welcome to another episode of the Neurocritical Care Society podcast. It is a genuine honor and a pleasure to be joined by Dr. Robert Kowalski and Dr. Joe Giacino as we discuss their paper titled Recovery of Consciousness and Functional Outcome in Moderate and Severe Traumatic Brain Injury, published in JAMA Neurology in March 2021. Dr. Kowalski is a research instructor in the Department of Neurology and assistant clinical professor in the Department of Physical Medicine and Rehabilitation at the University of Colorado School of Medicine. He's an experienced researcher in traumatic brain injury, has published on a range of topics, including the neuroanatomic factors that contribute to disorders of consciousness and how those factors relate to outcomes. He also previously served as on the editorial board for the Neurocritical Care Society's quarterly news publication, Currents. Dr. Joe Giacino, also joining us today, perhaps needs no introduction, but he's professor of physical medicine and rehabilitation at Harvard Medical School, director of rehabilitation neuropsychology at Spaulding Research Hospital, and a consulting neuropsychologist at Massachusetts General Hospital. He is an eminent expert in disorders of consciousness, having served as co-chair of the Aspen work group, which developed the initial criteria for minimally conscious state, and has a long history of very successful funded research aimed at better understanding disorders of consciousness, improving our diagnostic accuracy around disorders of consciousness, and improving patient outcomes after brain injury. Really, I'm thrilled to have you both here today. I feel compelled to mention that actually several of my colleagues in neurocritical care actually emailed me within a week of this article coming out saying, hey, have you seen this article? Check it out. So I think that there's just already a tremendous level of enthusiasm and if I may say, hope actually around the work that you've published here. By way of introduction for our listeners, in the neuro ICU, I think I have to tell families of patients with severe traumatic brain injury that I wish I had a crystal ball. I wish that I could tell you what the future holds for your loved one. And I often wish that I could be more definitive, but there's considerable uncertainty around any prognosis that we can offer. Interestingly, most in-hospital deaths after severe traumatic brain injury in particular occur after withdrawal of life-sustaining therapy, despite very limited information about long-term prognosis. And so in the present study, Drs. Kowalski and Giacino give us, I think, a glimpse into the functional outcomes of a very large cohort of patients with moderate and severe traumatic brain injury. And I think in doing so, challenge some of the presuppositions that we sometimes make about the potential for recovery of patients with traumatic brain injury. Dr. Kowalski, I'd like to start with you. Tell us about what inspired this study and what was your goal in conducting the study?
Happy to do so, and thanks for having us. The idea for this study arose in a disorders of consciousness working group that exists within the TBI Model Systems program. This includes a number of leading researchers in the world of coma and disordered consciousness, including Dr. Giacino. And we discussed the idea that it would be useful to look at the acute phase of care for these patients, that being the initial hospitalization and the subsequent inpatient rehabilitation that they receive. There's a fair amount of research and publications done on longer term outcomes, looking out years after injury in these patients, but something of a dearth of research during that acute phase. And so that's what gave us the idea to look at this.
With that, could you just tell us a little bit about the methods that you used in the study and then sort of segue into the main findings that you had?
Absolutely. So we used a very large database that's been collected over the past 31 years of survivors of moderate and severe traumatic brain injury. This is a project called TBI Model Systems. And we looked at patients who we looked at patients over a 3-decade period, and we broke them into 2 groups: those who experienced a loss of consciousness immediately after brain injury and those who did not. And we further broke them into groups of those who continued, who had persisting DOC at the time they were admitted to rehab, and those who were not. And then we analyzed 2 primary outcomes, those being recovery of consciousness and functional status as measured by the FIM scale at the time of discharge from inpatient rehabilitation.
And I want to note just for our audience with neurointensivists, I think we're most used to dealing with severe traumatic brain injury. But in this study, I think you're including moderate and severe TBI, and the criteria that you use for that are not necessarily strictly by Glasgow Coma Scale, which is I think what we often think of as neurointensivists. You did do a subgroup analysis, though, is that right, with patients defined by GCS less than or equal to 12 for moderate TBI, and you found the same thing. Is that correct?
That's correct. The criteria for inclusion in this large study, this longitudinal study of TBI patients, is the following: a GCS total score less than or equal to 12, post-traumatic amnesia lasting at least 24 hours, a loss of consciousness for at least 30 minutes, and or evidence of mechanical injury on CT of brain. So that's different than a simple GCS total score less than or equal to 8. So what we did, and partly in response to reviewer comments for this paper, was to look at comparability with a straight GCS score criteria. We did a subgroup analysis looking at those patients who we did have full GCS scores on, less than or equal to 12, and compared that to our overall findings, and they were remarkably similar. That gave us confidence on the generalizability of the results from this study.
Yeah, absolutely. I did have a question. Dr. Giacino, I know you're the director of the Spalding Harvard TBI Model System, which is one of the sites that was in this database. You mentioned it a little bit already, Dr. Kowalski, but Dr. Giacino, could you tell us more about what the TBI Model System is, what it's used for, what types of hospitals and patients are included in this database?
Sure. So this is the largest and longest running longitudinal database in the world for moderate to severe TBI patients. It's been around now for almost 31 years. It is housed in the National Institute on Disability Independent Living and Rehabilitation Research, which is part of the ACL section of HHS. Currently 16 funded centers. So to qualify as a TBI model system, one has to have a level 1 trauma center that's affiliated with an inpatient rehabilitation program. So all of the sites have a level 1 trauma center. And then there's the National Data and Statistical Center that houses all the data. To date, there are over 15,000 patients in that database. And among those patients, over 40,000 follow-ups have been completed over the 3 decades. So it is a gold mine of data. It's publicly accessible, and many outside people mine that database as well as the members of the TBI Model System program.
Really interesting. Thank you. It sounds like such a rich resource. Just waiting, I think, for more questions to be asked, probably.
Oh, absolutely.
One question I had about the methods. So for this study, you defined disorder of consciousness as the inability to follow commands. We know that sometimes consciousness can manifest as in other ways, more subtly, short of following commands. Could you tell me a bit about why you chose command following as a surrogate for consciousness in this study? And what do you think are the implications, if any, of that decision?
I'm happy to grab that one if you don't mind. That's a great question, and we were asked that by the reviewers also. And we talk about that a lot. The reason that we did that, the reasons are several-fold. First, there's a great deal of inter-rater reliability issues with the GCS total score. Second, there's a very well-known and actually, this was acknowledged by the developers of the GCS at the very start. There's a problem with the GCS as applies to obtaining the verbal component in patients who are intubated. Everyone knows that. Third, the ease of administering the motor component of the GCS is far greater than doing the GCS total score. And finally, in our patient population in the TBI model systems study, 25% of the patients we didn't have a GCS score on because they were either intubated or sedated or paralyzed. And so we opted to use the GCS motor score as our criterion for DOC. And finally, I would say that there is a very substantial growing body of evidence that the GCS motor component is in many ways a superior predictor of outcome in these patients than the total score. This is not universally accepted by any means. However, the body of published evidence on this is growing. So that gives you a summary of why we did it.
Thank you. That makes sense. I wonder if perhaps you could comment on the outcomes you observed and how those outcomes either corroborate or perhaps disagree with findings of previous studies. Obviously, no previous study that I know of has been this large, but how does this fit into the literature context that we already know?
Happy to take that one. Can I just make one other comment about the last question?
Sure.
You raised a really important point. I want to make sure listeners are very clear on this point. It is important not to look at this population as inclusive of all patients with disorders of consciousness, because command following was the proxy. So there are many patients who do not have command following, but have other definitive signs of consciousness that we don't know how many of those we captured here. So that's important to think about in understanding the representativeness of this study. Going on to your question in terms of how our knowledge of outcomes is potentially extended by these results. I'm really gratified by the results of this study, in part because we have been seeing this same finding of about at least 20% of individuals who have prolonged disorders of consciousness early in recovery. If you follow them over the course of at least 5 years, about 1 in 5 or 20% go on to regain functional independence. So what does that mean? Generally, that means they are able to live at home unsupervised for typically 8 hours a day, if you use Glasgow Outcome Scale extended standards. And why 8 hours? Part of the reason for that cut point is because that allows other family members to go about their business, to work and resume life as usual. So it's an important sort of milestone. And I don't think this is appreciated. So if you're looking at these individuals, particularly in the acute period, when they're in the ICU, and there is disturbance in consciousness or complete unconsciousness, the problem that we have right now is the biology of the natural history of this condition doesn't sync well with the demands of the healthcare system, which are to make these really vital decisions early before we really can do that with any degree of confidence. We published a study last year in the Journal of Neurotrauma showing that if you look at patients who are all in vegetative state or minimally conscious state, and this is after TBI, a very large percentage, on the order of 30 to 40% of those individuals, don't begin showing clear signs of emergence of consciousness until at the beginning, 6 weeks post-injury. So that expression of the behavioral signs of conscious awareness doesn't begin to happen in a large percentage of people until 6 weeks post. That's way past our usual decision-making window for goals of care discussions. So I think that's a really important point to take away from this study and some of these others. To sort of sum that up, this study, like others, but now in a more robust manner, extends knowledge of the length of time. So recovery extends beyond 1 year post-injury, and how much recovery can occur over time in these individuals.
Yeah, point well taken. I think functional independence certainly makes sense as an outcome. I was wondering, so you use the functional independence measure scale, and I was wondering what prompted you to choose that as opposed to something like the GOSE, the Glasgow Outcome Scale Extended, which I think we see more frequently used in TBI research. And perhaps even a broader question, what is the best outcome, the patient-focused outcome that we should really be focusing on in these types of trials?
I'm happy to take a first shot at that. So the FIM is, it's a scale that has 18 components, 18 elements. 13 of those are motor tasks and 5 are cognitive tasks. The FIM is the standard within the rehabilitation world for outcome. The GOSI is more of a standard in the neurology world. The TBI Model Systems study uses both. For the rehabilitation phase, the FIM is used, and for the 1, 2, and 5-year outcomes after discharge from rehabilitation, the GOSE is used. So we use both. And Dr. Giacino, I'd welcome any expansion on that, but I think that's the primary reason the study was set up in this way.
Yeah, no, I think I completely agree with that. In terms of the question of what's the best measure, I have to say, I don't think we found it yet. So, the GOSI is going to be around. I don't think the GOSI is going to go away entirely, but the TRACK TBI study, for example, is taking a really hard look at the Glasgow Outcome Scale Extended. Just within the last couple of weeks, a paper just accepted in Journal of Neurotrauma on a new manual for scoring the Glasgow Outcome Scale Extended, which is going to, I think, improve the inter-rater reliability and sharpen it up a bit, which we know is needed. We know from the TRACK TBI study where 4,000 people roughly have had GOSIs performed, that there's a lot of treachery, if you will, in the GOSI. So we used a central curation system and had literally thousands of queries that had to be addressed. So clinical use of a measure like that is really a problem because of, it's a very finicky measure. So we need to do a better job. I think the bottom line is that where things are going to move in the not too distant future, with the help of machine learning and with the help of with biomarkers, so blood-based biomarkers and imaging, where we'll be able to create a new classification system that doesn't just look at what the person is doing at the bedside, but is able to call into play blood-based biomarkers and imaging findings. Again, I'll cite TRACK TBI because I think it's really pushing the limits now in that direction. So we'll have a profile for every individual that is comprised of blood-based biomarkers, imaging, and then these clinical indicators, which I think is going to give us a much richer classification system. The idea that we take everybody and we put them into mild, moderate, and severe categories given the heterogeneity of traumatic brain injuries is a little silly.
Agreed. In that vein, we know that the detection of consciousness, particularly in the acute phase, is hindered by a lot of different factors, delirium, sedation, I could go on. But we know that the use of standardized tools, even clinical tools, for example, the JFK Coma Recovery Scale Revised, which, of course, Dr. Giacino, you were instrumental in helping create. So my question is, do centers in the TBI Model Systems database regularly document CRSR? If they don't, why not? What are the limitations? If they do, why not use that as a metric in this particular study? And then more broadly, is there, as you mentioned, Dr. Giacino, is there a utility for advanced neuroimaging or EEG methods to help classify consciousness in a study like this?
Two great questions. On the first one, so the short answer is no. The TBI Model Systems does not have as a data element the Coma Recovery Scale Revised. Why? It comes down to cost. So it's the cost of the staff to be able to perform that measure. Simply put, the TBI Model Systems program is underfunded. It has been underfunded for many years. So it's not for lack of will to do it. It's literally not feasible under the existing funding. Now, having said that, there are a group of about 6 or 7 model systems that use the CRS in clinical practice. And they have sort of formed a separate module where we're able to do studies that incorporate the Coma Recovery Scale because they all use it. And that's been a big help. There's 2 other kind of important points here. One is that there is now consideration of bringing the CRSR into the mix in the model systems. It would potentially to become a required data element, but it's going to be piloted before we move to that step. There will be some tweaks on this to limit the cost of doing it, obviously, based on what I said before, but there is a possibility that may happen. Let me just cross to your other question. What would we see if we applied advanced imaging, advanced electrophysiology to patients who were getting the CRSR? So I think what we have seen in the literature is somewhere, and Zach, you're aware of this quite well, somewhere between 20 to up to 30% of people for whom no conscious awareness was detected show signs of conscious awareness when you use these techniques. Whether the number is really 20 to 30%, 2 to 3 out of 10 people, I don't know yet. And I'm holding my judgment on that until we have a multi-center imaging or multi-center EEG study. As you know, we have all single site studies. There are some studies that involve more than one center, but these are combining retrospective databases together. But no one has actually conducted and carried out procedures with fMRI, with FEEG in the same manner, analyze the results in the same way. That's what we need before we decide what the percentage is. I have no doubt that we miss people with our best standardized bedside approaches. There's no question. Whether it's 2 to 3 out of 10, I'm going to reserve judgment on.
I agree, and I think it's always a balance. I think in studies like this of study size versus using more sophisticated metrics that may limit the number of patients that you can enroll. But point well taken. One question for Dr. Kowalski. All of the patients in this study were discharged from the hospital to acute inpatient rehab, and for an audience who is interested in neurocritical care, my question is, what do you think the relevance of your findings is to patients in the acute setting? In other words, how should we extrapolate your findings to the neuro ICU?
In terms of decision making and on the next step,
right? Exactly.
That's a fantastic question. It goes to the heart of the reason that we did this study. Our overall findings were that of the 12% of the patients who had persisting DOC at the time they arrived at rehab, 82% of those recovered consciousness by the time they left. These are patients who had DOC persisting all the way through the acute phase of care. Furthermore, the trajectory of functional recovery during rehab was actually slightly better for the patients with DOC than for those who were fully conscious at the time they started. We think that this is an important finding and a lesson to physicians and other clinicians who provide care during the acute phase of care, including the neuro ICU. There's hope for these patients, even when there's whether it's acknowledged or not, there's a perception that patients who have persisting DOC have a worse prognosis. And at least in our sample, we found that for a good percentage of them, the outcomes were good. They were very good. 40% of these patients who had a disorder of consciousness when they arrived at admission to inpatient rehab were either partly or fully independent by the time they left. That's pretty remarkable.
I agree. I think that's a really pleasantly surprising number, and so I think really encouraging. What do you make of? You commented on it there. What do you make of the fact that people with DOC actually had more recovery, or even a faster trajectory of recovery than patients without? That seems somewhat counterintuitive.
There's a big caveat to that, and we made this really clear in our findings. They start lower and they end lower.
Yeah.
And it's really clear, and we further broke it down and we looked at it for each of the decades in the study independently to see if there was something that was changing over time, and the trajectories were almost identical in each of the 10-year periods. So we think there's a natural process going on here. So they start lower and they end lower. The fact that they made a greater recovery by a small amount, a 43-point improvement versus 37-point improvement on the FIM scale, we don't really know what to make of that, but at least it's encouraging.
And let me just jump in, if I could, to come back to something Dr. Kowalski said, because this point should not be missed. He said that 82% of individuals recovered consciousness, if you define that by recovery of command following during the inpatient stay. If you look in the paper, you'll find another line that says that 2% of individuals continued to have disturbance in consciousness on discharge from rehab, if you count the acute stay as well. So we're talking now about a figure that's 98%. So you can shake your head and, be a doubting Thomas about that, but I'm going to tell you that we have another study that's in review right now that's going to say the same thing. Believe it. So I just think we need to take a minute and think about that. So basically what we're saying is that if you've got disturbance in consciousness and you survive, the chances are there's going to be recovery of consciousness over the course of the first year. How much recovery of consciousness? Well, you heard a little bit about that. Bob just reported the number 40% who were partially or fully independent. Prior studies showing 20% with full independence. So there's your answer about what do we take from this when we go back in time, the first 28 days. We need to be really cautious.
Yeah, no, here. In that vein, as I mentioned at the beginning, and as you all know well, most in-hospital deaths for patients with severe TBI occur after withdrawal of life-sustaining therapy. So this is a speculative, if not a bit provocative question, but do you think your findings would be similar or different if withdrawal of life-sustaining therapy were never pursued in the acute setting?
Because I'm jumping out of my seat, I guess I'll start. I have no question that they would be different. Not only does withdrawal of life-sustaining treatment account for the majority of deaths in TBI that occur, but the decision is made within 72 hours on average. That is the median time to the decision. So let's go back to what we said before. If we know with some certainty that most of the important indicators that are behavioral indicators that are going to suggest subsequent recovery aren't going to emerge to maybe 6 weeks out, how can we make these decisions at 72 hours for the majority, probably for the majority of people who are in this position? I think we simply can't do that. So we have this major disconnect right now between the timing of decisions about withdrawal of life-sustaining treatment, the number of cases in whom we pursue that option, and the downstream recovery that will occur in a substantial minority of people who are in the same place as those who have withdrawal of life-sustaining treatment. That have to fix that. And one way to fix it is to slow it down, not execute that option as frequently as we do. So again, I have no question the numbers would look different.
If I could just add to that, the numbers on this are pretty stunning. As you mentioned, for moderate and severe TBI patients, as many as 44% die during the acute hospital stay. And of those who die during that stay, somewhere in the range of 44 to 87% are as the result of withdrawing life-sustaining therapy. This is something that, it goes to the issue of what's referred to as the self-fulfilling prophecy, something that Claude Hemphill and others have been talking about and researching for a long, long time. As Dr. Giacino said, it seems there's no question that some of these patients would survive were those decisions not made. And again, this is very complicated, and especially in the neuro ICU world, where the results of being discharged to a skilled nursing facility instead of rehab, have very important implications in family discussions and so on. But those are the numbers, and they're hard to ignore.
Yeah, I think it's pretty clear that more caution is warranted in these types of situations. I wonder, Dr. Kowalski, you've studied this a lot in terms of outcomes and the neuroanatomic factors that contribute. What things can we look at as clinicians in the acute phase to help guide decisions about prognosis? just broadly looking from this work, it's clear that we need to give more time. But are there other factors? Can I look at someone's MRI or CT and say, and perhaps that would change the answer that in the discussion that I would have with them?
The CT findings for this study, we had CT results for all of these patients. They're based on radiology reports and not on research analysis of the imaging. But nevertheless, on a macro level, what we did find are somewhat predictable, intuitive results, that being substantial midline shift greater than 5 millimeters of midline structures, blood in the ventricles, damage to subcortical white matter regions. All of these things on a macro level are fairly easy to see on the CT. And we think, and all of them, when we ran multivariable models, came out as predictors of poorer outcome. And the absence of these findings predicted better outcome. So we think those are some objective tools that are available to acute care physicians.
Thank you, Dr. Kowalski. That's helpful. In the introduction, you briefly mentioned at one point, which I want to reiterate, particularly for our neuro ICU listeners. You mentioned that we know that one of the barriers to improved outcomes in patients with TBI is potentially inaccurate diagnosis and prognosis at the beginning. But you also noted that patients with disorders of consciousness may be less likely to get specialized inpatient rehabilitation. And so my question is, what are the barriers to access to specialized rehabilitation for patients with disorders of consciousness? And what can we do about the apparent disparities in access to that type of care for these patients?
Let me start by kind of at a high level. I think we can summarize it by saying that most patients in the United States end up getting pretty state-of-the-art care. We have an amazing trauma system of care in this country. They get state-of-the-art care. There are no thoughts about the resource consumption that goes into saving someone's life for the most part. Mm. They finish that stay and they step off a cliff, because once we move to the post-acute world, it changes. Literally in a 24-hour period from the moment they leave that center and move on to the next level of care. What does that mean in practice? It means that from the best evidence we have, it looks like 1 in 5 individuals who sustain moderate to severe traumatic brain injury ever see the inside of an inpatient rehabilitation center, which means they're going to other places, skilled nursing facilities, home. And now the care and the shift in responsibility moves to the family, largely. These are not facilities that are equipped with to address the specialized needs of this population. The recent guidelines that were published, the AAN, ACRM, NIDLR guidelines in 2018 on management of disorders of consciousness, the first guideline states that it is important for these individuals to have multidisciplinary inpatient rehabilitation, following the acute care stay. And it is precisely because the needs are highly complex and the training level is specialized. So if 1 in 5 people are moving into settings without specialized staff training and resources, equipment, that's a big problem. What happens to those who do get in? The lucky 1 in 5. The stays are short. So, it's not uncommon in some places, people have gotten into inpatient rehab, they're there for 14 days and they're on their way. That's still nowhere near the amount of time that's needed to sort of just size up that individual and figure out what the needs are, predict what the downstream needs are going to be. So we have that problem. Once they leave the inpatient setting, follow-up at that point is often non-existent. In my state, the state of Massachusetts, there are very few subacute facilities left at all that have any specialized programs for patients with severe brain disorders of consciousness and severe brain injury. So they're really left to be cared for in settings that are used to providing palliative care. And this is not a population that needs palliative care. Often they're younger, right? Much younger. So I think we have a policy issue on our hands, and we have a payer issue, because right now the gatekeepers are the payers. And the payers are able to do the gatekeeping because there are some policies and regs that are in place right now that, quite frankly, discriminate against this portion of the healthcare population. So if the more severe your injury, the less likely you are to receive care or be authorized for care. That has to be fixed. I think we need to join forces across disciplines, neurocritical care, rehabilitation, join forces, become one voice, pull the data together, and really begin the lobbying effort aimed at both policymakers and payers to say, the time has come to stop the inequity and the marginalization of this population.
And yeah, I completely agree. And I think, what an inspirational message, but also what a charge for all of us, I think, that we need to face, moving forward. No question. With that, I want to ask, what have I not asked you about that you think is important, that you'd like to share with listeners? What have we not discussed that you think is an important takeaway?
I would just jump in and say, in terms of takeaways, going back to sort of the preamble that you gave and what the comment that you made at the very beginning and we've talked about a bit, and that is that these important decisions are made with this population of patients during the acute phase of care. And these are very difficult decisions families have to make, that physicians have to make in terms of discussions with the families. And as we've noted sort of ad nauseum, there's a very large percentage of patients for whom the decision is made not to continue life-sustaining therapy. And we think that the results of this particular study at least suggest that there should be caution. Not that there isn't already, but at least give more onus to caution in making those decisions. And I think that's the takeaway. That's an important takeaway message from this research.
And maybe I can just use the last couple seconds to make a plug to that does address Dr. Threlkeld's question. The Neurocritical Care Society has recently launched the campaign to cure coma. This past weekend, starting on Sunday night and Monday, there was the first World Coma Day, global event to raise awareness of disorders of consciousness, from the scientific side all the way out to clinical practice. It was a really amazing event that went on for, close to 36 hours or so. So what can people do? I think they can get involved in this campaign. This is being described as the moonshot for disorders of consciousness. You can go to, I think the website, I had it up a minute ago, is www.curingcoma.org. And lots of ways to get involved. But this is going to be the first cross-disciplinary, decade-long, NIH-backed initiative to really make some advances here. So plenty of room for people to get involved. Take a look. That's one way to do it.
Thanks, both of you. I agree. In such an exciting time, I think, for coma research and in developing this multidisciplinary approach, I think, which is the only way that we make progress. Thank you both, really, for taking time out of your busy schedules. I think this is just such interesting and profoundly important work. So I really look forward to reading more of your work in the future. Congratulations, both of you, on this publication. And for our listeners, thank you all for listening. I hope you enjoyed it. Please join us again for our next episode. This has been the Neurocritical Care Society podcast. Thank you.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threlkeld, Teddy Yoon, and Chris Zaman. Our administrative staff and senior producer is Bronnie Rousseau. Music by Mohan Katapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.